It is my pleasure to introduce our speakers during this segment. Each section will be followed by a question and answer session moderated by myself and Ryan Gove. Each speaker will have an allotted time to present, and I will give each speaker a 3-minute warning to keep our schedule on time. And we will have links to each of the PowerPoint available after the program. So without further ado, I'd like to introduce the next speaker, Dr. Alice Zhang. Dr. Zhang recently joined the Department of Occupational Therapy as a faculty member. She just completed her postdoctoral fellowship affiliated with Casey Lend, the Kansas Center for Autism Research and Training, KCART, and the Telehealth Rocks Project. Dr. Zhang is a behavior analyst and has research interests on increasing service access for families of children with an autism spectrum disorder and other developmental disabilities via telehealth technology. She provides clinical services, including OASIS, parent training, and behavioral consultation through both in-person and telehealth clinics. Dr. Zhang is passionate about advocating for healthcare access and disability rights. Welcome.
Hi, everyone. Can you all hear me?
Yes, ma'am.
Thank you. I appreciate it. So it has been such a wonderful day learning from all speakers. It just brings in so much wonderful experience and data and information. So again, my name is Alice Zhang, and so I want to talk today about sharing some thoughts and stories about having providers with disabilities, why it matters. So I do want to share a couple of facts about myself that would help you understand the context of some of the stories I will be sharing. So in addition to being a behavior analyst who work with children with ASD and other developmental disabilities, I have been a wheelchair user since childhood, and I grew up in China, where people with disabilities have long been marginalized and still are, like many other developing countries. We are 80% of people with disabilities on this planet live. Next slide, please. That slide is not the slide. Oh, yes. Thank you. So, so I came to the University of Kansas for my doctoral study in 2012. In the past 8 years, I have had the privilege to learn about disability rights and educate myself to be an advocate for myself and others. I want to shout out to Dot for being such a great mentor in my, learning to be an advocate for myself and also for others. So I have come to learn that I have equal rights to education and employment, and should be able to choose what I want to do based on my interest and skills. It felt like a great sense of liberation. So however, when I was working on my postdoctoral fellowship application for the LAND program at KU Medical Center, I experienced quite some self-doubts. And I asked myself 2 questions. Can I work in a healthcare setting as a wheelchair user? Would I be given the equal opportunity to be considered for this fellowship? I asked this question because I have been told many times in the past, you cannot do this. You cannot take this PE class because we don't have activities for you. Or you cannot work as a counselor in a high school because you cannot protect the students if there is an emergency. So I also have never had any experience seeing anyone with disabilities working in a healthcare setting in the past. So next slide, please. While I was anxious about these questions, I did a search, a Google search. So as shown on the PowerPoint slide, there's a screenshot of a Google search page with the keywords doctor in wheelchair, with a couple of videos showing doctors in wheelchairs. I thought if a wheelchair user can work in the hospital setting as a doctor or nurse who do surgeries or other procedures that require a lot of physical skills, then that means I can, work in a healthcare setting as a behavioral analyst. So I am glad that I did that search. I watched a lot of videos of people with different disabilities talking about how they become doctors and nurses. Knowing people who have a similar experience as I do, similar disabilities, and they have already done something that I want to do, makes me feel really hopeful. So my application was successful and I became a Land postdoctoral fellow. I remember I came to KU Medical Center to attend a presentation before I started my postdoctoral fellowship. So during that trip, I got lost while I was trying to find the classroom where the presentation was. I asked the lady, who must be a patient transporter, how I can get to where I needed to go. So the lady was so helpful, and she insisted on taking me to the classroom after I told her that I was not there for a doctor appointment. So on the way to the classroom, she insisted on pushing my wheelchairs after I told her several times I would rather do it myself. I can do this. And I explained to her again several times that, I'm not there for a doctor's appointment. Oh, sorry, next slide, please. And once we found that the classroom, she opened the door and said to a room full of presenters and attendees of that presentation, the patient is here. And I just remember that experience so vividly. That's just, an experience, I believe that is not a unique experience to myself. It probably has happened to other people with disabilities who work in a healthcare setting in different capacities. Next slide. So for people with disabilities, it's also not a rare experience for their competency to be doubted in obvious and or subtle ways at times. So this can be true, especially in a healthcare setting where people with disabilities, have been traditionally considered as patients who needed to be fixed under the traditional medical model. For example, the screenshot on the slide shows a picture of a woman in a wheelchair with the title, "I use a wheelchair, and yes, I am your doctor." So this is a New York Times article that you can also search, access online as well. So this article wrote by Dr. Sherry Blauvett. She's an assistant professor at the Harvard Medical School who also happens to be a wheelchair user. So in this article, she gives some examples of her own experience not being treated as a doctor when she first met other patients or other people who are not patients because of the fact that she sits on a wheelchair. And she also shared that I find that these reactions are somewhat generational. Younger patients, having grown up amid a growing awareness of disability in society, typically do not react at all. They have clearly encountered empowered people with disabilities working in various professional roles. Older patients often seem confused, curious, or in rare circumstances, dismayed. The point here is that we can have biases because of how we were influenced by our environment. As a person with a disability myself, I also have biases because I grew up in an environment that do not empower people with disabilities, that do not treat people with disabilities equally as people without disabilities. So I recently saw an occupational therapist for myself. I remember the first time when I saw my therapist, I was a bit surprised because my therapist uses a wheelchair just like I do. in fact, his injury level is higher than mine. So my first automatic thought was, how are you going to assist me with exercise if you have more impairment than I do? So that thought of doubt dissolved once I started working with him and seeing him working with other patients as well. So I guess I want to say it's okay to have, unconscious biases, and we all do. And working with people with disabilities or seeing people with disabilities working in professional settings, like in a healthcare setting, can really create opportunities to challenge those biases and for us to all to grow. Next slide, thank you. So I also want to talk about why does it matter to have providers with disabilities. I think the first thing is because we do not have enough of them. So according to the CDC data from 2018, 26% or 1 in 4 adults in the United States have some type of disabilities. And using medical students and physicians as an example, the Association of American Medical Colleges, or the AAMC, in 2018, in their report, they said that only 0.5 to 5% of medical students self-reported as having disabilities, and only 2% of physicians were identified as having disabilities. I acknowledge that's already a lot of progress have been made compared to many years ago, like what Dr. Hosh shared, like doctors cannot be doctors, they have to be forced to choose another path. But still, we just do not have enough providers with disabilities. I think having providers with disabilities, no matter whether they are physicians, nurses, psychologists, OTs, PTs, or other disciplines, it really can help reduce the stereotypes and the stigmatized view on disability. So I think first, people with disabilities are not inevitably in need of a fix or dependent on others for care. Evidence shows that people with disabilities often rate their own quality of life much higher than others rating their quality of life. And subjective satisfaction of disabled people is usually comparable to that of non-disabled people. Moreover, physicians and other healthcare professionals need to accept that many people with disabilities do not necessarily perceive their disability as a problem or pathology. So having providers with disabilities can also help create a more accessible and inclusive environment. And ultimately, I think that will improve the care for people with disabilities. Next slide, please.
We have 3 minutes left.
Thanks. So what can we do to help to have more providers with disabilities working in healthcare setting? I also want to share this report from AAMC in 2018. They shared some promising practices regarding improving accessible inclusion. And I think those promising practices can apply across settings and disciplines. And one of them I want to highlight here is the universal design to both physical space and learning experience. And a universal designed environment can benefit more than people with disabilities, can benefit us all. Another tool and important guideline and a law that I want to mention here, which already has been mentioned by many people today, is the Americans with Disabilities Act. And its accompanying 2010 ADA Standards for Accessible Design is another very important tool to help us make sure we make our environment more accessible. Again, there are limitations of those guidelines. There are things we can do much better beyond that. But at the same time, let's make sure we can at least enforce what we are required to do. So one example that I always think is that having a sign of disabled parking put in a parking space does not automatically make a parking space accessible. I feel like, I don't know, I feel like a lot of times people don't realize that. So anyway, finally, I want to challenge you all to scan your physical or internet environments and think whether your environment is accessible. Is it accessible for individuals with mobility-related disabilities? But also, is it accessible for individuals with other types of disabilities? I think that it is important to think about what we can do as an individual, a unit, or a department, so that we can work together to create a more accessible and inclusive environment that will ultimately benefit everyone. Thank you. I think I have a slide of resources, but I think that will be shared later. So thank you.
Thank you so much. That was perfect. We have about 5 minutes for question and answers. I saw a great comment here by Spencer Hunley. He wrote, people pushing others' wheelchairs without their consent is still a major problem.
Yes, I think, you know, based on my personal experience, I just feel like there's a lot of education that needs to be done. Not just with patient transporter, but I think they're important because they're often the first line of people you see when you go to a healthcare setting. So I think having that courtesy to ask, do you need my help? Do you need me to push you? I think it will be really, really important. But I also have recently gone to some doctor's appointment, both at KU Medical Center and I live in Lawrence. So there are also nurses who just their first they go to my chair right away. And I was just like, okay, I think I can do this myself.
I think it's that instinct to help, right?
Yeah, I think I really, really appreciate, you know, the intent behind that.
Mm-hmm.
But, you know, there's a better way to do it.
We had another question here. Can you explain how a parking sign doesn't make the parking space accessible? What should be considered?
Yeah, so there's a lot of information, you know, legal requirements that would make a parking space accessible. So, for example, you need to have access aisle, and so that, you know, people with using wheelchairs or other, you know, assistant tech equipment can use that space to get in and get out their car. And particularly, there's a type of parking space called van accessible parking space that requires a total space width of the parking space and the access aisle to be 16 feet. Am I saying that right? Dot, please correct me if I said it wrong. So a lot of times that what I see is that, you know, it's just a regular parking space, just like there's no access out, there's nothing, the width doesn't meet any requirements. But then there's a sign that says disabled parking. And then I was just puzzled. I was like, how is that sign make this thing totally different now?
Thank you. Do we have any other questions from the audience?
Other thoughts?
No? Okay. Thank you very much. Moving on, I have the pleasure of introducing Gina Schwartz. And I'm going to pronounce this last name in English. I'm a native German, so my brain automatically wants to read it in German. So forgive me if I do. Gina Schwartz is an occupational therapist and graduate teaching assistant within the University of Kansas Medical Center Occupational Therapy Education Department, while she works to obtain her post-professional occupational therapy doctorate degree. She practices occupational therapy primarily with adults with mental illness in acute hospital and community settings. Her long-term goal within her practice and with her doctorate degree is to expand the knowledge of the value of occupational therapy services for individuals across the mental health continuum within the greater Kansas City area. Welcome.
Thank you, Christine, and thanks for saying my last name correct. Can be a toughie. Thank you all for having me this afternoon. So as Christine mentioned with my bio, my main area of interest and passion is in mental health. So, you know, one of the questions that came to, that came to the speakers was, what do you believe is most important for providers to know, do, or recognize when providing healthcare for people with disabilities? The first thing that I thought about when approaching this presentation was that there are disabilities that are seen as like invisible disabilities, and mental illness, I think, absolutely falls under that category of invisible disabilities. So I want to talk to you guys today about some ways that we view mental illness within the healthcare system as a whole, some of my perspectives as an occupational therapist, but provide recommendations for interdisciplinary practice. So some other things that I think are important for us to know when working with or interacting with individuals with mental illness goes along with trauma and trauma-informed care. It's important to recognize that individuals seeking mental health care have likely experienced trauma at some point in their lives. I think this is really true for the disability community overall. We are understanding trauma in a different way than we have in the past, where we used to see trauma as something that happened with our vets or our emergency service workers, but we're understanding trauma in a different way these days, as the way that not only an event happens, but how we experience and process events in our lives. So with trauma-informed care, one of the most basic assumptions is that we just assume that anyone that we might interact with has had the potential to experience trauma. So this is something that we can use with individuals with mental illness, or really anyone seeking healthcare services. Another thing to keep in mind with trauma-informed care, if it's something that is new to you, are some ways that you can promote a space of safety for all individuals. So first of all, we can make safe environments by getting people to trust us and being transparent and open with them, providing support from peers, collaboration and mutuality with individuals, empowerment and choice, and understanding cultural, historical, and gender differences. These are parts of trauma-informed care. Another thing more specifically to keep in mind with individuals with mental illness is that cognitive difficulties are very common among individuals, particularly with serious mental illness. These individuals also can experience difficulties with social skills. So I think these multidimensional difficulties can create challenges in some of the basic things that we do, interviews, assessments. So they can be worked around. So professionals like occupational therapists can be helpful for kind of working around some of those barriers. And another important thing to keep in mind is that mental health is on a continuum. I think we all understand that we have mental health, but mental health is on a continuum where there's wellness and then there's illness, but then there's a lot of area in between that. So understanding what that continuum looks like and being able to provide the most basic services across healthcare for individuals experiencing different challenges within that mental health continuum is important. As far as errors or omissions that I think are common in healthcare settings for individuals with mental illness, The biggest for me being in an allied health profession as an occupational therapist is that we tend to just not assess or not even address mental health because we see ourselves as not psychiatrists or psychologists or social workers who may more stereotypically address mental health needs. But I think individuals in the allied health professions, particularly occupational therapists and physical therapists, by the inherent work that we do, restoring function and performing and increasing performance capacity, we address individuals' mental health, but we can't do it in a roundabout kind of way. We have to address those things specifically. As far as barriers go for individuals within the mental health care system who have mental illness or are seeking mental health care, I think the biggest barrier is stigma. I heard about a study the other day that they told a story of a person who was addicted to drugs, and then they told the same story of an addict. And the compassion that was showed towards the person who is addicted to drugs versus the addict was very different. There were a lot more punitive conversations regarding the addict. So stigma is very much alive and well, both within our society and our healthcare system. We continue to believe that mental illness and addiction are associated with character flaws. We continue to perpetuate the idea that individuals with mental illness are dangerous. That's evident in our media. We fail to seek equity in healthcare services. During Obama's term, the Parity Act came about, but we still do not have equity within mental health care compared to our healthcare system as a whole. So stigma is really holding us back from providing equitable care. As far as guidance goes, for individuals who have family members or care providers who accompany them to receiving mental health care, I can relate with this as somebody who was a family member of an individual seeking mental health services, particularly for addiction. This can be a very daunting system to try to work in. Family members and care providers can be exhausted. They can lack trust in the system as a whole. So providing that trauma-informed care not only to the patient or the client, but to the family members is very important.
We have about 2 minutes left.
Okay.
Thank you.
No problem. And then the final thing I wanted to share were just some recommendations for healthcare providers who wish to be effective disability advocates. So the first place that I would start would be engaging in continuing education about trauma and trauma-informed care. This can be formal through formal courses, or there are great podcasts and videos out there. So just engaging in that education. Also spending time reflecting on the language you use while talking about individuals with mental illness. We use terms like crazy and lunatic and psychotic and addict and alcoholic, kind of throw those things around. We even use diagnoses such as OCD to describe seemingly harmless idiosyncrasies. So just thinking about the words we use and how we choose to use them. And once you are able to reflect on those things, working on modifying your language. I also would challenge you, once you go through that reflection and adaptation, to challenge others on their perceptions of individuals with mental illness and the language they use. I do this pretty often with my boyfriend, and you can get a little taken aback sometimes. And then finally, advocate for trauma-informed care trainings and processes within your department. Even if you don't work in a mental health setting, I think all healthcare settings need a trauma-informed care approach. So that's all I have for you guys.
Thank you so very much. Wonderful. Next, we have Jacob Marshall. Jacob is a sign language interpreter in the Kansas City area and also a social worker. Marshall has worked in a personal care attendant, independent living advocate, vocational rehabilitation counselor, video relay service interpreter, and has helped lead several ethics groups for the sign language interpreting community. Welcome.
It's great to be here. Thank you so much. I just want to check really quick. Can you guys hear me okay and see me all right?
Yes, we can. Thank you.
Wonderful. Okay, well, it's my pleasure to be here. I wanted to say thank you very quickly to Dr. Riddell for inviting me out. I'm really excited to begin. I have a short little couple talking points that I'd love to share with you regarding some of my experiences. So a little bit about me. I'm married with a 6-year-old dog child. We have a boxer. Her name is Tina. And I primarily work as a sign language interpreter, both in education, so that's secondary level, high school. And then I also do community interpreting, sign language interpreting in the area, including some medical. I also serve on the KU Edwards campus board for the Deaf Studies, Deaf and ASL Studies Advisory Board. It's a wonderful new program. It's advancing the profession and it's through KU. So I wanted to just bring up a couple things regarding interpreting perspective, regarding medical interpreting and interpreting in general, but specifically for this medical. So I got a resource from, it's the Civil Rights Education and Enforcement Center. The acronym is CREEC, C-R-E-E-C. And they have like offices in several states, Colorado, California, and Tennessee. It essentially kind of outlines some of the things that, you know, we being people who are involved in the medical professions and different careers in that, some things that we could think about regarding, you know, making sure people who are deaf and hard of hearing, as well as people who use sign language because maybe they're nonverbal for whatever reason. So one of the biggest things that affects service provision and what I do daily, no matter where I'm at, what location, is the Americans with Disabilities Act. And I think I heard Dr. Zhang mention it, the ADA. That requires that sign language interpreters be provided in the medical setting. There are several options on how that could work out. One option is a live interpreter, which that's something that I tend to do more so than the other option. That's where, you know, they contract, the hospital or the entity contracts with the agency, they call us out, and a physical interpreter shows up and we're in the room with the doctor and the patient, and it's, you know, a little bit more personal, I'd say. The other option is video relay interpreting, which I don't know how many people have experienced this before, but if you get a call from a person and it immediately starts off with, hello, this is Purple Video Relay Service, sign language interpreter number 6215. We are a person who uses sign language is calling you through this service. A lot of people hang up because they think it's a scam, but honestly, it's not a scam for the most part. It's a service, a national call center that, so let's say if there isn't availability or it's a last minute request, if a doctor or a therapist has a deaf client in the office, they could wheel in a screen, like it could be a laptop, it could be some sort of a device, a video conferencing device that remotely we could provide sign language interpreting services. One of the things that kind of stuck with me from Dr. Zhang's presentation is making the entire environment accessible. And what I kind of want to mention regarding that is having a sign language interpreter in a conversation, just adding them in, whether it's in person or VRI, doesn't necessarily make that interaction fully accessible. I'm going to get into why that is just a little bit later, but I wanted to talk about VRI and just a couple of things when you're thinking, okay, you know, should we call a live physical interpreter, or should we use the VRI system and just wheel it in, and, you know, the patient from their bed or sitting down or standing up, they could sign to the screen, and that interpreter on that screen will voice their responses and vice versa. But some instances where VRI is not okay, according to Creek, that reference that I said earlier. Let's say the patient who is deaf, hard of hearing, or nonverbal, they have limited movement in the head, hands, or arms. That may make it difficult for them to see the screen, for the interpreter on the screen to see them, and then also to just figure out, you know, everything that's happening. Because one difference in between like a in-person interpreter and a remote interpreter is that remote interpreter had no idea that they were going to be getting called for this specific assignment until the moment their phone rang, and they'd pick up. Well, actually, they'd pick up and they just click a button, and the deaf person and the doctor would appear on their screen. So there isn't a lot of prep time. So depending on the situation, you might really want to go with the in-person interpreter. Another one that VRI, video relay interpreting, the remote stuff, it may not be okay, is if the patient has a vision or cognitive issues, or is under the influence of drugs or alcohol. Again, without that interpreter having like background context and knowing, you know, having the opportunity to chat with the patient a little bit to see how they use language and, you know, their preferences, it's kind of difficult to instantly jump into a conversation and know what's happening, especially if it's an emergency like situation. There are several other things from this resource, and feel free to reach out to me or the organizers if you'd like this little like cheat sheet of quick things regarding medical interpreting and how to use sign language interpreting services. And yes, I see that up there on the screen. Perfect. They're really cool that they made a PDF, and it's easily attached to an email. So feel free to just get in touch with us. One of the things that I wanted to kind of close with are the local resources, because, you know, I could pop up here today and say, you know, XYZ about sign language interpreting, and then, oh, you have my email, but life is crazy, especially with COVID. So I wanted to give you a couple people and a couple places to maybe check in that will be here for a long time, that you could get some resources. So The Whole Person, that's WHOLE, The Whole Person. One individual that I have a lot of respect for, that she actually spoke earlier today during this conference, this symposium, is Michelle Keck, or Mickey Keck. She's an independent living advocate and deaf services specialist with The Whole Person, which is a center for independent living in the Kansas City, Missouri area. One thing that is super great about what they do is they have these community American Sign Language classes that are offered through them. And I could send out the link for that. I could send out this little page, just, you know, or you could contact Michelle Keck directly. She may even be on this call. But yeah, it's basic sign language that, you know, it's designed for people who are professionals as well as community members. So I don't know if there's an age restriction. I know at one time there wasn't, but it could be anybody. It could be, you know, if you work in disposal services, if you are a doctor, if you're a, you know, whoever, these classes are for you, because basic level, being able to sign a little bit, even though you're going to need an interpreter for that medical interaction, being able to communicate somewhat in somebody's native language is huge, part of cultural competency. So
We have about 2 minutes left.
thank you. And then also, Mickey Keck she holds presentations at The Whole Person, as well as in the past, at least, the Deaf Services Department has sent people out to different businesses, including hospitals, to lecture on things such as accessibility, universal design, how to use an interpreter. And I could talk about using an interpreter from an interpreter's point of view, but it's also just amazing to hear it from somebody who uses the services. It's just a totally different perspective. And She does an amazing job at it. So the whole person, that's like number one. And then I am also part of a group called the Kansas Association of Interpreters. It's KAIRID. That last part is a national affiliation, but essentially if you wanted to follow up with me at all, I do have my email that I could provide to the organizers if you wanted to follow up on anything interpreting related. If I don't know the answer, I'd get you to the right person that does. And yeah, just the last thing I wanted to close on is I love that person first language that the previous presentation covered. Instead of necessarily saying like, you know, the person who can't hear, you know, that person over there, or deaf mute or whatever. I mean, I wouldn't appreciate being called somebody who's the non-dancer. He can't dance at all, you know, and that's my title. From what I use, that tends to be accepted is, you know, a person who is deaf or a person who uses sign language. But yeah, thank you for the time. I really appreciate it. Thank you.
Thank you so very much. Thank you. Ryan, are there any questions or comments in the chat for our panelists?
Always.
Perfect.
Just some really great comments about language.
We have one more presentation before we do Q&A.
Oh, okay.
If that's okay.
Absolutely.
Sure. Okay. Up next, I am to introduce two people. I have Jessica Shetler, Dr. Jessica Shetler, and Chandra Gordon. Dr. Jessica Shetler is a psychologist in the Division of Developmental Behavioral Science, Pediatric on Training, Director for the Leadership Education in Neurodevelopmental and Related Disabilities Program at the University of Kansas Medical Center, Kansas Lent, and serves as KUMC Site Director for the Kansas University on Developmental Disabilities. In addition to that, we have Chandra Gordon. She received her bachelor's degree in sociology and women's studies from Kansas State University and a master of social work from the University of Kansas. She's a licensed master level social worker who has been providing services and support in the greater Kansas City area for more than 20 years now. She's employed at the Center for Child Health and Development at the University of Kansas Medical Center, where she provides support in various pediatric specialty clinics. She's also a faculty in leadership education in neurodevelopmental and related disabilities, LEND program. She has an extensive background in mental health facilitation, training, program development, quality improvement, and community advocacy.
Okay.
Welcome.
Thank you so much. Thank you, everyone. It's great to be with you. It's been just so powerful to listen all day to the presenters who are sharing their different expertise and perspectives, and to hear from all the folks just participating and engaging in this symposium today. So my name is Jessica Shetler. And I do serve as our training director for Kansas Leadership Education in Neurodevelopmental and Related Disabilities program. I am also a child psychologist. And I also want to make sure my colleague Chandra Gordon gets the chance to introduce herself. She'll be co-presenting with me today. We both work in the Division of Developmental and Behavioral Sciences, and we're both LEND alumni. So Chandra, if you want to introduce yourself before I start off with slides, you're welcome to.
Yes, I'm Chandra Gordon, as Dr. Shetler shared, social worker working in the Center of Child Health and Development. Again, have a passion for a lot of the different topics that we've talked about, and I feel my overall desire is helping individuals maximize their potential, and that's potential whatever that may be. So again, glad to be able to share with you today information about our program and and exploring all the different collaboration opportunities that I've made throughout the day.
Excellent. So on our next slide, we're providing an overview just of what we want to talk about in our time that we have with you. We want to give you an introduction to our LIND program, share a little bit about our efforts to implement best practices in accessibility and inclusion in our program and the impact of that on our learners and learners nationally participating in these types of programs. And we also wanted to share resources that you all may find helpful as you are beginning or continuing to examine your program's accessibility practices. So you might be wondering, what is LEND? So on the next slide, we have a little bit of information about that. LEND stands for Leadership Education in Neurodevelopmental and Related Disabilities. We are a workforce development program, so that means we train what we call emerging leaders in the field of developmental disabilities. So whether your field is direct healthcare provision, working in a community setting, education, or advocacy, we want to work with you. We bring diverse cohorts of folks from graduate school, our community members, family members, and people with disabilities to explore leadership and what that means in the context of maternal and child health populations. So we focused historically on kids and families, but we are increasingly seeing the need to really look across the lifespan and think about what leadership means in providing supports and partnerships across that. We also provide training and supports through partnerships around the state to build the capacity of our community partners in supporting individuals with developmental disabilities and their families. The way that we define and develop leadership are really guided by the Maternal and Child Health Bureau and their leadership competencies, which could be thought of as a set of concentric circles with kind of beginning with ourselves. So our own self-knowledge, self-reflection, thinking about what we need to learn and how we need to first grow, and then expanding to think about our influence on others. So partnering with others in culturally congruent and people-centered ways, and the ways that we work together to help people develop into their best versions of themselves. So we think about that really broadly across our different disciplines, whether that's our patients and clients, our students, or our colleagues. That outer ring then of this concentric circle of leadership development focuses on our impact on the wider community. So we develop our understanding and learn about various types of service systems, and also learn about practices to influence policy at local, state, and federal levels. On the next slide, we designed this to highlight a bit about who LEND is. So the slide contains photos of over 35 different folks, and this is certainly not all inclusive of our LEND network, but I hope we hope it begins to give a sense of the start of the folks who help make LEND what it is. So this group of folks includes not only our 16 long-term trainees who represent 12 different disciplines with us this year, and some, but not all, of our incredible faculty members who represent over 14 different disciplines and also span across the Med Center, our KU Lawrence, and University of Missouri Kansas City campuses. And we're going to talk a little bit more about the kind of demographics of our trainees in a little bit. On our next slide, we designed this to share with you a little bit of how we learn with and from one another. So we do that through 5 different ways of learning, which could be represented as petals on a sunflower. The ways we learn include through coursework, clinical, community-based research, and personal leadership development opportunities. In each of these areas, our learners and our teachers work together to support learners in working towards individual goals in each domain and in advancing the work of our faculty. So again, driven by those MCH populations and their needs and our MCH leadership competencies. One quick example of this really relates to something we were speaking to about medical education earlier. We have a LEN trainee with us last summer who did a survey of students across the Med Center, both the medical students and allied health professionals, and found that around 50% of them reported moderate to really low amounts of knowledge around developmental disability, and really speaking to the need for more curriculum related to that. And so now this year, we have a set of LEN faculty and trainees who will be working in partnership with our consumer advisory panel for the Kansas University Center on Developmental Disabilities to develop some curriculum materials that will be embedded into the learning modules for students doing the ACE curriculum this year. And there's a little bit of research around that. So we're really excited about that small step towards trying to address the need for additional provider education and understanding. On our next slide, I want to just offer to you some takeaways about how we've so far worked to embrace the multidimensional experience of our learners and our stakeholders. I want to acknowledge we still have much work to be done. We share these thoughts with you in the hopes that it's the beginning of continued conversation across programs, across our campuses related to this work. So we have 4 R's you might think about. First R, recruitment, thinking about who you're bringing into your program. What pipeline opportunities have you created? And no matter your program, you will benefit by incorporating disability perspective. Reception is our next R. We're working to ensure our physical spaces as well as instructional materials are accessible, and relationally thinking about how we support our trainees to feel they belong, to make the hidden curriculum of being at an academic medical center more clear, to help them connect personally with one another and professionally with each other and with colleagues across the campus. The third R is representation, and so we seek to not only represent a variety of experiences and backgrounds in our learning materials, but we also expect our trainees to get involved in our program committees and lift their voices to provide feedback and input into our ongoing programs. It also means we have to clarify how we represent information across different disciplines, so translating what an acronym in one type of discipline might mean to someone else. And lastly, if we want to be representative, we also have to practice responsiveness. So to quote Brene Brown, who was also mentioned earlier today, we want to worry less about being right and instead focus on getting it right. So when we get feedback from our trainees, we seek to respond to it in the short term and the long term. And I'll turn it over to you, Chandra.
All right, as Dr. Shetler has said, again, our program is one of 52 LEN programs in the United States, and our overarching association is Association of University Centers on Disability. And so when we begin to think about the overall focus of the program, it is to increase awareness, understanding, and as well as promoting inclusion of awareness and understanding of disabilities, and promoting advocacy and opportunities for those with disabilities. So with our reach, what we really strive to do that, and as what Jessica said, is through a variety of different avenues. And so just looking at the national impact of the LEN program, in 2018, we trained a lot of trainees, and just thinking about the overall roles in which they've landed. So 56% of the former trainees basically noted leadership roles in their clinical activities, 40% in academic activities, 13% in public policy, and then 12% in public health activities. The whole goal of LEN is also, again, as we've talked about on this call today, throughout today's event, is how are we getting the tools, the knowledge, the resources into the hands of practicing professionals, upcoming professionals, even thinking about caregivers as well as disability advocates. And that's what the LEN program represents. Again, how are we doing that? And then also thinking about the reach from our program from a national perspective. So within 2019, there were over 4,600 long-term trainees trained, again, from 47 different disciplines. But then of that group, 61% of those trainees were actually LEN trainees. Again, looking at the reach and the impact that we are having, and those individuals coming through the program and actually getting opportunity to have that additional training, knowledge, skills, and experiences as it relates to developmental disabilities. Next slide, please. So when we think about the LEND impact just on a Kansas level, when we went back and we really wanted to look and see again, as we think about, we can speak to, data shows us, we can look at data from national, local, or state levels as far as the number of individuals with disabilities. We can break it down and even think about those individuals with the types of disabilities. But what this graph really represented and why we felt was powerful and important to include is just thinking about the number of individuals we trained. We have 3 different cohorts of trainees. We have short-term, medium-term, and long-term trainees, all based on the number of hour commitment individuals are able to engage in for our training program. But what this data definitely represents is for the trainees that we trained between the years of 2015 through 2019, which we trained over 2,000, the majority of our trainees that came into our program had no personal relationship with disabilities. So again, it's not so much about training those with the lived experience or the caregivers of those living with that experience, but how do we increase the understanding of those that have no knowledge, exposure, or understanding of it? And then again, our next largest demographic data was that it was not recorded in response to having a relationship with disabilities in our survey. Next slide, please. So when we think about, again, being responsive, as Dr. Shetler said, it is about how are we using data to make our data-driven decisions. So as we know, as we shared earlier today, definitely what we decided to do is to get a climate satisfaction survey and really modeled it after the actual organization-wide climate survey. We wanted to know how well were we doing within our own program as related to developmental disabilities. So we began to administer an annual LEND satisfaction survey and wanting to know, are we meeting the mark and what can we do to continually enhance and grow and improve our program? So just thinking about what can we do to continue this effort? And so when we think about, so we looked at the data, so during the program years of 2017 to 2019, because our program does run on an academic calendar, we had a 97% satisfaction rating regarding the course topics. We had an 85% satisfaction rating regarding the range of developmental disabilities covered. And then also 95% of our trainees recommended LEND to the program. Now, we all know that it's always great, it's always wonderful to be able to present great satisfaction ratings, but these satisfaction ratings were not always as high as they were. What we were able to do is use that annual data to improve the things that we did in our program, such as increasing the course content as related to the variety of different disabilities that we taught, as well as the course topics. So again, how we continue to be responsive. Our program consists not only of individuals that are in grad school or practicing professionals, but our program also consists of individual self-advocates, those that identify as having a disability, as well as caregivers. That can be an actual parent, it could be, a grandparent, a sibling. So our training cohort is definitely an interdisciplinary group with a variety of different individuals from the lived, I would say professional as well as personal experience. And then also just sharing some of the personal perspective from LEND trainees. And this is just some feedback that we received on the survey. One trainee reported, "I'm very grateful to have been in LEND training. I was exposed to a breadth and wealth of information and experiences that will richly inform our practice moving forward." And that was from a trainee who went through the program between 2017 and 2018. Next slide, please. So as we begin to come to a close, one of the things that we were challenged with in our presentation is to really think about, Jeff sent us some questions and really challenged us to think about how could we address things in our program, in our talk as it relates to what should we know, what could we do, how can we look at the barriers that we face, what are ways that we can effectively advocate in regards to disability. But I think it really comes back to the 4 R's, and we've talked about those in regards to recruitment, reception, representation, and responsiveness. And so what we ask and encourage each and every one of us to do is to think about what is one thing we can do to think about ways in which we can promote inclusion in the work that we do, in our training programs, and even in our own personal lives. Again, we think about a lot of times it's a mountain to climb, but what are the small steps? What are things that we can do? And so again, our program, as we say, is not perfect, We continue to strive to be responsive. We continue to strive to make sure we are representing correctly. We strive to continue to make sure that we are received appropriately, and then also recruit appropriately. So again, we continue to strive that, and we have an ongoing program for the LEND program. A lot of the topics or training needs or some of the concerns that were shared throughout this discussion today, Jessica Shetler and I, as well as Alice Zhang, we have all been texting each other privately and even in the chat, just like excited because within our own house, we have a lot of these resources. That's what our LEND training program is designed to do. How do we help build capacity? So we definitely will go to the next slide. Share resources. And one resource that we definitely want to share is, again, research on how to get information about the LEND program. Again, this is a program, again, based on an individual's interest in learning more and growing more, based on the amount of time commitment that an individual has. Again, it is a program that is available as a resource, not only internally, but as well as to the greater community. That is exactly what our program is designed to do. Some other resources that we encourage you to consider exploring is also the maternal child health leadership competencies. Dr. Shetler went over those earlier in the presentation as ways of guiding our competency growth from self, moving on to others and into the larger community. Also, when we think about universal design, what does that look like within our own individual practices or workplace or community settings? There's some, again, different guidance there. And then finally is the Diversity and Inclusion Toolkit. Again, other ways of looking at practical tools, tips, and strategies on how we continue to work toward all the work that is needed to be done in the sake for inclusion for all. So again, as I'm coming to a close, again, our information is there regarding LEND. We have a lot of information to share. I definitely say that all my colleagues are definitely excited about all the potential opportunities to be able to share resources as well as other tools of information internally. And then if you're interested in getting information, certainly please reach out. We would love to speak with you.
I also want to give a quick shout out to our LEND alum that presented today. Stephanie Coleman and Alice did an incredible job. And thanks to all of you LEND trainees who attended today and engaged all day and offered great perspectives and insight as well. It's awesome to see you all here.
Thank you so much, Dr. Shetler and Chandra. With that, I would like to ask if there are any questions or comments.
Lots of LEND shout outs. Everyone loves LEND. ELL, everyone loves LEND. That should be the motto.
I want to recognize LEND real quickly for receiving the Diversity, Equity, and Inclusion Award in 2019. At the time it was the EVC's Diversity, Equity, and Inclusion Award. That's when I first heard about them, and it was fortuitous timing because we were looking at this symposium at the time. So that gave me the opportunity to connect with LEND, and it's a phenomenal group that's been doing phenomenal work for so long. So thank you for your leadership.
Any questions for any of our last handful of presenters?
You know, I have a question, Ryan, about intersectionality between culture, language, and having a person with a disability or caring for.
Too hot.
Okay, I don't think she was responding to you. So just thoughts on intersectionality of language, culture, and disability. Any of our friends care to pick that one up?
This is Jake Marshall.
Hey, Jake.
I have a comment for that. Yeah. So I'm aware my colleague, Dr. Petra Horn-Marsh of the University of Kansas Edwards campus, she's part of the Deaf Studies program and interpreting studies. She actually just did a workshop on intersectionality specifically to being deaf, and I think maybe some other languages in there, but I can maybe reach out to her and get the contact information. I could connect whoever's asking that question to that.
Hey folks, this is Jeff Riddell. I'm just about to enter something into the chat. It doesn't need to be read, but it is a resource that I think addresses this intersectionality. It has to do with a recent documentary called Feeling Through about a deafblind individual. And most importantly, how it was presented at the Kansas City Public Library. They did a phenomenal job of engaging the community, and it is one of the probably preeminent examples of how to do it right. I don't know if other people had the opportunity to, are aware of the documentary, but I'm putting in the chat a link to a New York Times article about it, because the backstory is fascinating. And if you have a chance to watch it, it is really cool. It's even better if you get a chance to watch it with a deafblind individual. It's absolutely fantastic. Okay, so it's related to the intersectionality part, but maybe more about how to manage teaching or introducing about it.
So thanks for sharing that information, Jeff. In terms of intersectionality, I feel like one thing is that to recognize, people with disabilities also have other characteristics that can be very important to them as well, no matter whether it's race, gender, or sexual orientation, and also understanding, people with disabilities, in general, we as a group, there are disadvantages in equity, but among people with disabilities, if someone is also having, if it's a person with disability who happens to be also a Black person, or having a gender, sexual orientation that is not the mainstream sexual orientation, they might experience a lot more than, a person with disability who do not have those characteristics. Kind of like what Dr. Hall mentioned earlier about people with autisms, and when they are, also belonging to LGBTQ community, they experience many, many more barriers when they are trying to access, appropriate health care that can support them, instead of discourage them. So I think that's a very important topic. That's when we talk about disability, we want to recognize there are so many other intersectionalities that can impact a person's healthcare and quality of life. And also I think, so I worked with families who, who speak primarily another language. And for example, I worked with families who speak Chinese, and also understand their cultural, where they're from potentially can also impact how they consider make their healthcare decision. And even though they're children with having autism, even they are growing up in an education system that is saying, okay, this is fine, but still there are also cultural perspectives considering why is my children having autism? Is this something that I did wrong? All those cultural perspectives that their parents may have inherited or learned in their previous, cultural background could potentially affect how their children are receiving education or medical care. So I just feel like that's such a, complex, but also really, really important topic that I'm trying to navigate myself as a clinician, also as a researcher. But thank you for bringing up that really great question, Kimberly.
Thank you, Dr. Chung. And I'm wondering, Dr. Chung, and I don't mean to put you on the spot too much, but you know, I work with international students. So my heart is with international students. And, you know, since meeting you, you've told me so much and you've educated me a lot by just what you've told me, and I really appreciate it. I have had the question and kind of the, just curious, because we know when an international student comes to the United States, just like how overwhelming that can be to go to a new culture, new country, potentially pursuing a degree in a second language, and just how much anxiety and worry that can provoke for someone. And with you, I was wondering, you know, again, that intersectionality of coming to the US and also having a disability, like, can you speak to how that was for you and how that transition was for you at the time? Do you remember? I know it's been a little bit.
Yeah. So again, I came here in 2012, and one of the major thing that I felt like I already shared is a kind of sense of liberation. Is because, you know, I don't know how many of you have been to a country that is not very accessible. Again, there are still many things we can do in US to make it more accessible, but if you have been to a developing country, you as a person with a disability, a lot of times people say is that we don't see people with disabilities on the street. Why? Because they cannot get out of their home. So, so when I came here and I realized, okay, I can actually request an accessible, at that time I was living on campus, I was able to request the accessible apartment, and KU provided a wonderful service to me, which for other students or staff with disabilities is the bus that they will pick you up from your apartment and take you to wherever you want to go for your study or learning. So that was something that I never experienced, and I just felt like all the things that I learned in the past about how you should do things, like advocacy, is definitely not something that I learned when I was in China. So in China, I felt like I was taught to like appreciate what I can get, and anything that is not be given to me, I should just, you know, I don't know, hope that good things will happen. So it's not there's not a system, there's not a law like Americans with Disabilities Act that can say, okay, you know, this is my right, this is a accommodation I need to have, and there's a process, and there's not that process. So I'm like relearning all the things about, oh, okay, I actually have rights. And so I think that's the most part that I've learned. And also I mentioned Dr. Dalton plays such an important role in helping me learning all those things. I remember you know, learning the concept of disability pride versus, like, you know, disability shame or all those type of things. And I was like, oh, you can be proud of your disability. You can be proud even though you have a disability. So all those type of things really is like, I felt like I just totally relived as a person with a disability. So I appreciate that piece. And now after 8 years being in US, I felt like I'm beyond that stage that I felt like everything's perfect or wonderful here. And I can see things that we can still make improvements. But I think, you know, that's kind of the process to know that how environment can play such a big influence on people's behavior. So it's not that people in other countries do not want to have equal rights. It's that environment is not set up for them to have equal access. So I just felt like there are things that as we can do as an individual person, but also as a systematic level, we need to make things better so that people can thrive and be, you know, their best. Thank you.
Thank you very much. We have one more positive feedback in the chat. Angela Sass wrote, I have opened about 20 tabs in my browser with the amazing resources, articles, and opportunities that have been shared today. So excited to look into all of these. Keep them coming. And then with that, I would give it back to Dr. Jeff Riddell.
All right, we're in the tail end here, and of all of the things going on today, this is the section where I have the most concern because we have no speaker. The good thing is Dr. Dotneri, who's has spoken earlier, is willing to moderate this general Q&A session. So the goal in the next little bit until about 3:15 is to have a general discussion, to answer questions maybe that had been asked earlier and not answered, or where part 2 of the question now needs to be asked. Dr. Neri will guide us through that. I'll be hanging out in the background if needed.
Great.
I could read that whole introductory thing for Dr. Neri all over again. How about if you say 10 words just in case someone has dialed in just for this particular part?
Okay, I'm a
What
disability.
do we need to know about you?
I'm a disability researcher. I'm a person with a disability. I advocated at the White House for the Americans with Disabilities Act, and I'm very fortunate to work for the Kansas Disability and Health Program. How's that?
Perfect. Really nice.
Okay.
Succinct summary.
Yeah.
Can
I just want to say one thing?
Yeah, sure.
I have people working on my house and they've been hammering for about a half hour. So they weren't supposed to come till next week, but they started today. So if things get rough and you can't hear, I may throw it back to you, Jeff. But right now they're kind of quiet, so that's good.
That's all right. I have a wife who's practicing piano downstairs.
Oh, okay. Sounds good. Do you want to start off, or do you want me to?
You know, you've got them up there in front of you too. How about, look, here's one. Spencer just sent one in.
Well, I just want to say one thing first. I think we've had such a great opportunity today to share such a wide variety of types of information, research, personal experience, programs, and I've learned a lot, so I really appreciate that. So I think as a group, we've all addressed disability diversity in different ways, and we've all learned a lot. So I really, really appreciate that. And I think all the work that put into holding this event, you should all be very proud. So let's start there.
Thank you very much for that. But of course, without the presenters, it would have been strictly academic, and that wasn't the point of this whole experience. So thank you to the organizers, thank you to the presenters, thank you to the audience. Okay, now answer some questions.
Okay, I see one last question here. How has the recent modifications to the ADA hindered accessibility in this country? I don't think it's so much modifications to the ADA, but it's lack of enforcement, lack of attention to it, an effort to change it so that businesses would get notice of a problem they have when it's been in effect for almost 30 years, that they could get like, I think 180 days to remedy a problem, which they should have been doing something years ago. But I think the biggest thing is, as we've said before, is recognizing that the ADA is a minimum standard. It's the minimum that could get through to get it passed, and that there are many things, including healthcare coverage, that it does not cover. So I'm a huge fan, but we've got to recognize that it's not the be all and the end all to solving issues for people with disabilities. And I welcome other people to weigh in on that.
I agree, Docs, that enforcement is so key. I felt like that's the bare minimal. Like, we have a law here, let's respect the law and make sure that we do things to, you know, to make sure accessibility guidelines are being enforced. And I just want to say, yes, I totally agree with that.
And I think on behalf of healthcare providers, for someone to say that, oh, we comply with the ADA, that's absolutely tone deaf and really doesn't speak to meeting the needs and really caring for people with disabilities. So we really need to talk about the ADA, not to not appreciate it, but to recognize its limitations, and that we really need to go much further. Questions?
Spencer had a clarification to that question.
Oh, what groups' resources would you recommend regarding ADA law and implementation? Well, I think the first step would be to contact your local independent living center because they are there to do community education and to advocate around accessibility. Some other good ones are, let's see, the Disability Education, Disability Education and Rights Fund.
Education Defense Fund.
Yeah, in California, DREDF, that's a good one. But I think starting locally, because every community, the issues are the same and they're different, and linking up with people who are advocates, have been doing advocacy in the community, know what's going on locally, what's been done, where the problems are, that's probably your best start there. But, you know, finding people with disabilities who are active and advocates is a really good step, and you'll probably find them through an independent living center. Someone says, will you explain the 180 days? I don't even know if I have the 180 days correct, but it was an effort where if I went to a business and they were not complying, especially a large business that I know has resources, say their bathroom wasn't accessible. If I filed a complaint, that, and I'm not saying anyone would follow through on it, but that business would be giving an extra period of time to before they would be liable. So they've had 30 years, but they would get an additional period. I think it's 180 days. Don't quote me, I'd have to go back and check. But they would get additional time to comply when they've already had all this time they were not in compliance. So that's why I mentioned that. It's really a non-issue. If it's the law, you should have complied years ago, and you shouldn't get extra time to do that. It's my job to know the tax law and pay my taxes. It's a business's job to know the accessibility regs, just like they comply with electrical codes and the other types of things. And we need to regard accessibility in that vein.
Alice provided clarification for the 180 days, broke it down, and the bottom line is it's not instant or certain for that matter.
Mm-hmm. Okay. Oh, I see, Alice. Thank you. Thank you. Thanks for looking it up.
Spencer had a part 2 of his question, which was originally recent modifications to the ADA hinder accessibility, but his clarification was specifically the ADA Education and Reform Act of 2017. Okay.
You know, I can't even comment on that. I mean, I'm aware of it, but I don't know the specifics, and I don't want to give wrong information. Does anybody else?
That's the law. That law.
Okay.
Is the one that would impose the 120-day wait period.
Okay. Right. Okay.
But it didn't pass.
Right. But it's always working,
out there.
I think. Yeah. I mean, there have been efforts to depower or make the ADA less enforceable and less stringent, and we all need to be aware of that because, again, it doesn't cover everything. We need it to be stronger, not weaker. But it doesn't get to the issue we've talked a lot about today, which is attitudes. When people with disabilities are considered less than, we will never achieve what we need to do to make things equitable and to deliver good health care. So I think that's an important thing to remember. I think everyone's tired.
I'm scanning backwards through the chat history to see if we missed anything. Anyone else who would like a question while I'm doing that, feel free.
I would encourage everybody too to follow up on Dr. Hall's presentation and go to the health disparity fact sheet that is included in the resources, because, you know, when you look at those numbers, you see why this event is so important, and everybody's efforts to look at how people access healthcare and how it's provided is so important. It's not the only issue involved in health disparities, but it's an important one.
Can I make a comment, kind of question?
Sure.
You mentioned how today has been a lot about attitudes, and I was just struck with the thought that, you know, unconscious biases come from society, you know, from what we're told, our family, marketing, education. I mean, they come from all over, right? We're kind of barraged. And we've really looked at this a lot with relative to the situation of institutional racism. And the fact that a lot of the thoughts and ideas that we're taught are internalized. It's not just that white people have these, you know, hold these ideas and are racist, but also Black people can feel them about themselves or toward each other. And I was curious, like, relative to individuals with disabilities, the impact, you know, on a person who is subject to, you know, these messages and being told, you know, like negative messaging about having a disability and kind of the toll on a person.
I think that's a really important point, and I'm sure others will jump in. I just wanted to share that, you know, for people with disabilities, I think it's especially important to link with peers, because if you are an African American, most likely you're in an African American family, or you have other contacts in that community to boost your pride. If you're the only person in your family with a disability, you may not have role models in that setting and people who affirm your rights and your value as a person. They may as a person, but not particularly as a person with a disability. So, and I see Alice shaking her head, I think we've both found out that peer connection has been really important to our ability to take pride in our resilience and to negotiate society as people with disabilities. And I'm gonna let other folks jump in. I see Jean, Stephanie West Potter. Anyone wanna share anything there?
This is Stephanie Coleman, and I'll share.
Yes.
You know, when Matthew was in high school and we were doing his transition planning and IEPs, we talked about day service programs and just entry-level jobs for him. And I said, well, he wants to go to college. That wasn't even on their radar for him. And it's always been that for me, you know, and at some points I've asked people, I'm like, am I not doing the right thing? But, you know, I've always kept it positive for him that he can do anything. He can do whatever he wants to do. It may take more time, it may be harder, but he has the strengths and the abilities to do just about anything he wants to do. So, I mean, from my perspective, I've always just kept it positive. I've never said, well, you can't do that for him, and just supported him along the way.
Great.
Now, he's not going to be the Royals pitcher that he wanted to be at one time, but, you know, we've refocused.
Neither am I.
Yeah. We refocused that desire and still be with the Royals as a cameraman. So,
and I think that feedback is important from families, from educators, from healthcare providers. I mean, it needs to be a concerted message, and I think that's why Matthew's doing so well. I think that's great.
I know for me, I actually developed a training that is for people with mental illness called Overcoming Self-Stigma, because it is so ingrained that what society says I'm supposed to be because I have a mental illness. I never saw anyone like me that, you know, was successful and able to stay stable. You know, I only saw what media was portraying, people in crisis, people just unmedicated. And So it is something that then affects the way a person sees themselves and what, you know, for so long, I couldn't even imagine that my life now was even possible. Like I said, because I didn't see it. And when you have that feeling about yourself, it's really hard to get out of that cycle. All the treatment in the world doesn't help it if you feel horrible about yourself based on your diagnosis. And so I really think that, like Dot said, the peer support is so important, just to see other people that are similar to you. You know, everyone's different, obviously, but we're all going through things that people can relate to. And also just developing an environment that is safe to disclose and to talk about mental illness, especially, and not feel like you're going to be judged or, you know, people get scared, unfortunately, still. So it is definitely, sorry I went on about this a little too long with it, but it definitely is something that self-stigma is definitely huge, especially in the mental health community.
This is Jeff. From my perspective, people who are concerned about speaking about disability, or speaking about any difference, actually, not just about disability, people who are paralyzed by their concern about appearing insensitive or appearing wrong or being corrected are missing out on a learning opportunity. And, you know, sometimes you got to make a mistake and learn from it. And so taking that risk of speaking out, asking questions, putting yourself out there a little bit, not as the person necessarily with the disability, but as any individual in society, be open to that learning experience. Be open to asking, you know, am I on the right track? Could I do it better? What feedback do you have for me? And at least in my experience, if you do that with an honest approach and an open mind, it'll be a positive outcome. You will learn, other people will appreciate your effort.
I appreciate you saying that, Jeff. I was just going to add, that's kind of referencing this idea of allyship, which we haven't talked as much about in the disability space of diversity as well. So I just appreciate you bringing that up. It's something that we're exploring more in some of our programming and lessons. And so I just appreciate having this audience to think about that with too. We've talked a lot about being like an accessible provider and a good partner in care, but like, what does that mean also to be an ally in other spaces when disability conversations are coming up? I think Gina made great points to that too. Around language, just great points all day. And I guess nobody really used the word ally yet. And so I just thought I would throw that out there in the interest of kind of building our language about talking about this.
Thank you for that.
It's interesting you say that because we, the group is not active now, but we had a group at the University of Kansas called AbleHawks, and it's a disability awareness group. And one year the group changed it to AbleHawks and Allies. To recognize that people don't accomplish things alone. It takes a group and it takes everybody. So that's a great point, Jessica.
That's a great program. We've had several LEM trainees who have experience with that program and was some of their first introduction to disability. And so that's—
Yeah, I've referred a lot of people to LEM. That's great. I see there's a question here. I'm a med student pursuing physical medicine and rehab. I'm just wondering if you had any tips, advice for a future physiatrist to help serve my future patients better. I think we could really delve into that. Does anyone want to share anything? We probably have a few things to offer.
So I have some recent visits to rehab medicine. So I feel like, you know, to be honest, I was a little bit disappointed about my experience because I have very high expectation because I thought if I'm in a rehab medicine office, I should be experiencing things that are totally accessible and totally person-centered or patient-centered. But I felt like maybe rehab medicine should be kind of the role model in the hospital for other, you know, departments in some way. So I felt like maybe just really, when you think about the physical environment, the attitude environment and everything, and really, because we are talking about like that modeling, I think knowing that you can be a really positive model if you are in rehab medicine, and knowing that you can positively impact a lot of other providers, I felt like that's a lot of responsibility, but it also means that you can do a lot of great work.
I think I would want, particularly a physiatrist, to ask me what my life is like and what my day is like, so that provider can get a picture of who I am. I remember a couple of years ago, I was really sick in the hospital. I had a crash cart call and I probably looked like hell. And of course, I've got a medical record stack about, foot high. And I had a rehab nurse that day. I wasn't in rehab, but I had a rehab nurse. And she looked at me at one point and said, "And what did you do when you were able to work?" And that just knocked the stuffing out of me, because I had every intention of recovering and going back to work. And it just took me aback. And she had a student with her. And for the student's benefit, I said, "I work as a disability researcher and educator, and I will be back to work in 6 months." And I was. But, don't assume. And it just, that could have delayed my recovery if I wasn't a pretty strong person and resentful of that. So I guess find out who the patient is. Don't go by the medical records. And I think probably a lot of people here could say that. So
I would add, don't think that you need to quote unquote fix a person. I mean, we talked about that a little bit.
Yeah.
Meet them where they are. If it's about maintaining function or finding a different way to do something, and that's what the person needs or wants to do, meet them there.
Yeah.
Don't impose ideas about what you need to do to fix their lives, because they probably know what they need.
Mm-hmm. I'm not seeing any more questions. Anyone just want to share? Someone is saying, how do you want to be addressed? How do you explain your abilities? I'm not sure what that means. I would just say that I do things like other people. I can't do some things, but most things I may do differently, but I do them. So
No, I think, Dot, I think the question is, how do you interact with your patient? What do you ask them?
Oh, okay.
The question is, how do you want to be addressed in that sense?
So is that for providers? I'm confused.
Yeah, I think that's how I read it.
Okay.
I was just reading it as someone saying, I learned so much from asking those questions when I'm meeting new clients or patients.
Oh, okay, I get it.
Right.
Yeah, that's good. Yeah. Those are good questions. Oh, and then someone says that reminds me to say we should always question the use of the word normal. And I agree, because that makes some things abnormal, and it's not true. So
that reminds me, during our Pride Month, we had a conversation about the word queer. And one of our leaders, he was studying this idea of like, how do I say this, denormalizing the idea of being normal, I think is the best way to explain it. And that like all of us are different. And as soon as we put up like the standard of normal, it makes everyone feel less than for whatever area that they may feel that they're lacking in. So whether it's a physical disability or other identification, that we can make just inherently this sense of being maybe not complete or not normal or not up to standard.
Sounds
I've always found it fascinating that for a society, the American society, that values independence and self-determination and all of those things, that we use the word normal like the word average. And why would I want to be normal? You know, I'd rather be the best person I can be. And I recognize there's a lot of work to do still.
I think in relation to healthcare, we have a lot to work to do to make society accessible, because healthcare is a reflection of our values in society. So, you know, as long as we have to fight to have an interpreter to attend a city commission meeting, as long as we're still building houses with steps and not changing the housing stock, as long as parents have to spend inordinate amounts of time often fighting the special ed system and you know, working on IEPs. Not that that isn't a good thing, but I know it's a struggle for a lot of families. So I think we all have to look around us and how can we all work to make society more accessible and welcoming to people with disabilities? Because again, I think the healthcare system is a reflection of society. So I think we all have some responsibility to look widely in our communities and our social circles, and to do education and awareness raising around these issues. And that's what I was trying to get at with my comments on diversity, and that we're not really, we all need to practice it in our own lives so that we can be models for the community.
Dot, I absolutely agree with you there. You know, being open and learning of new things all the time. A couple of years ago, Alice went to DC with us before, and I've never traveled with somebody who uses a wheelchair. And so it was eye-opening for me. I mean, we had problems getting into I can't remember which building it was, whether it was a rep building or senator building, but and then another building, they're like, well, she has to go down to the other door, you know, bathroom issues, just everything. And then it just opened my eyes up. And so now when I'm out and about and I look at things and I'm like, well, this wouldn't be accessible. I wouldn't be able to bring Alice along with me here. You know what I mean? But I think you should learn from those around you, constantly be open to learn from those around you.
And they didn't even trash your chair that time, Alice, right?
Actually,
oh.
I think that was the trip.
That, yeah, I think that I'm sure you have
events that we take for granted is difficult in terms of visual and oral communication. So yeah, we've made progress, but we've got work to do.
Dr. Neri, I will confirm that as someone who has a profound hearing loss and bilateral hearing aids. Travel is extremely difficult. And people, because it's not something people see, they question it all the time.
Right.
Like I'll go up and say, I need to pre-board because I don't want to miss the call for my flight or, you know, whatever. And they're like, well, why?
Right.
And I'm like, because I had one person at airport told me that, well, I would need a letter from my doctor in order for them to accommodate me.
Yeah.
Okay. So, I mean, hotels are, it's all the same, but it is extremely difficult. Right now with COVID and masks, which I am a supporter of wearing masks and all of that, but it's added a level of difficulty in communicating because you don't realize how much you rely on lip reading until that's taken away from you.
Right. And I don't think people realize how exhausting it is to have to do 5 extra steps to accomplish something that a non-disabled person. I think people are becoming more aware as population ages, and maybe caregivers have to deal with it too. But there's a lot of extra steps to negotiate the everyday things that people do. And it's tiring.
I hear that airlines are especially insensitive to the expensive equipment that they might have to transport and aren't careful with wheelchairs and such, which could be a great, if it gets broken, I mean, you think about if it's damaged and I'm traveling, that means I'm arriving somewhere without my wheelchair, and then the airline may not reimburse as they should.
Yeah, or it may take 6 months to get the chair fixed.
Yeah, it seems criminal to me, really.
Yeah.
And someone sent a question to me, Kiki did privately, just because of the functionality of her Zoom isn't quite working. Can I read it? Is that okay?
Sure.
She says, I don't know if this is a reasonable question or even relevant. Is there accommodation within the ADA for individuals who have been seeking a diagnosis that recognizes that they have a disability, but don't quite have that official diagnosis for various reasons? I am wondering how included these individuals are and what accommodations there are for them or protections from the law in this space or wherever they find themselves pending an established diagnosis, particularly those with non-physical or invisible disabilities. Great question.
Well, the ADA, I'll jump in and feel free to join me. The ADA is focused on eliminating discrimination. So the person would have to show that they have been discriminated against in some way. So it wouldn't be so much on their particular condition, but how they experienced negotiating society and whether they experienced discrimination. And sometimes that may require a doctor's notice to get an accommodation, but it's a good question. It's pretty broad though. Does anyone want to jump in?
I want to add that, oh, sorry, go ahead, Jane.
I was going to say that if a person is perceived as having a disability, whether they have a disability or not, they're covered under the ADA. So if they are treated in a discriminatory manner because the person perceives that they have a disability, it doesn't matter if they have a disability or not, they're covered.
Right,
So,
right. Good point.
I was thinking of that from kind of a pediatric or childhood kind of educational system context too, about the idea of having a 504 accommodation plan does not mean you have to have a diagnosis. You can, and that logic that Jean used is exactly why. So,
I was thinking of for accommodations, you might need under the ADA, you might need a doctor's letter for some things, but you're right. And I think the example of what Jean mentioned was a person with AIDS. If their partner was considered to have a disability because they were a partner person with AIDS, they would be covered by the ADA.
And one of the other examples that you often hear is if someone has like a disfigurement, it's not disabling in any way. They don't have any limitations in their life, but if someone doesn't hire them because they don't like the way that disfigurement looks, then that they're being discriminated against on the basis.
Yeah. Does that answer your question?
So if that person were treated differently because they're somehow different, then potentially the ADA would cover them.
You know, this is why lawyers exist. Because, you know, it's very hard to parse the exact meaning of a complex law.
Right.
That is vague in some ways and very precise in other ways.
Well, and the ADA has built-in flexibility so that it could get passed. And so it isn't prescriptive, but it can be debated. So yeah, it's good in some ways and not so good in others.
So I have a question that arises through Leslie's question about this, or statement about carrying a strobe smoke detector in her suitcase when she travels, since it's possible she wouldn't actually hear the hotel fire alarm. Leslie, who came up with that idea?
Actually, my friend Mark, we were driving through New England, and I mean, he knew I had a hearing loss, but my audiologist tells me I do myself a disadvantage because I expend a lot of energy to be high functioning. But we were in a car and it was dark. Cars are hard anyway, but it was at night. And that was the first time he truly realized how much of a hearing loss I had and how that impacted things. And he said, so what happens if you're at home and the smoke alarm goes off? I said, well, maybe I hear it. I don't know. My dog lets me know. I don't know. He goes, well, what about a hotel? I said, I don't know. It's just life. I mean, he goes, that's unacceptable.
That's exactly my reason
Yeah, so
for
we had
asking
to-
this question, is that
Yeah.
people
No.
try to be very independent and they're usually successful until something like that might occur. And you know, who helps you think outside of the box is a really important question.
No, it is. And so he made me do research and we ordered one online before I left Boston.
I think under the ADA, hotels are required to have visual smoke alarms.
They're required.
Whether-
they don't
whether
always
you
put
can
you
ever
in the
get
rooms,
a-
even when you ask.
Yeah.
Yeah, it's kind of like relying on the alarm.
Yeah, exactly.
Yeah. That's the problem, is it just they didn't always have them. So
Right.
I'm kind of weird
Right.
in connection today. I apologize for the delay.
I think in general, hotel is an industry that needs to make a lot of improvements. And there are so many stories, and we don't have time to tell the stories with the hotels. But yeah, ADA can be improved because there are a lot of things, like for example, how high the bed is. That's not covered in ADA at all. So yeah.
I think one of the worst travel experiences I had years ago was I belonged to a division of the American Psychological Association, and I went to several conferences and none of them were accessible. And there was resentment around being asked to be inconvenienced by holding the event at an accessible place. So I am no longer a member of that division. I hope they have changed. But for someone in graduate school and wanting to learn and advance a career, that was very, very disappointing to not be supported by my colleagues. So next steps, what are we all going to do next? I hope we can keep the conversation going. This is important. It's important to meet and learn and share, but then what do we all go back and do?
I'm going to that conference in Lawrence next week or next month.
Oh, great, great. It's online now, you know that, but it'll be
Right.
good. Great. Yeah, Judy Human will be great.
One thing we're talking about in the chat is having a group, a follow-up like conversation with the participants today from the symposium. So we'll have a list of all the people that registered. If you, for some reason, didn't register under your own email, you can email us and let us know so that we have your name and we can add you to this kind of group email. We'll be sending out, of course, the assessment. We'll be sending out the link to the recording. We'll send out, again, the link to the resources, the booklet, the PowerPoint on our website. But we would also like, from the discussion, it seems like people are interested in getting together, like kind of continuing the conversation and the enthusiasm. So we'll be looking to organize some meetings, maybe quarterly or semesterly meetings where we can get together and chat and continue the allyship that someone mentioned.
Mm-hmm. That's a great term. Good. Can that be facilitated by the Med Center, or how will that work?
You know, I was thinking, I'm the programming chair for the Diversity, Equity, and Inclusion Cabinet along with Dr. Riddell. And we have a program called Community Conversations that cover a vast array of topics. And I thought maybe this could come under that umbrella potentially.
That sounds great. Yeah. And there were about 100 people, so that would be a robust conversation to continue. Great.
Yeah, we had over 200, well, right at 200 people register, so people were in and out.
Yeah.
But at any given time, we had 100 on, so
That's great.
Wonderful.
Yeah, especially on Zoom. It's it facilitates in some ways, but it's difficult in others, so that's impressive.
I am very impressed that we have so many people still here at the end of the day.
Mm-hmm. Very good.
I would encourage people to email other ideas that they have about continuing the conversation. They can email me, and yeah, we'll work together on that.
Great. I think we had such a range of, I'm just looking back in the list, the empathy training. We've had a really diverse types of information and resources. And I think reaching out to multiple constituencies was really, really important. So that's great. I learned some things. I think we're just about close to 3:15.
Right, we're right at 3:15. Who is going to introduce Geraldine for her closing talk?
Well, I don't know that I need to be introduced.
Oh,
I'm happy to step right in.
Speak up.
I'm here.
Go for it.
Well, great afternoon, everyone. And wasn't this symposium amazing? And I'm just wondering if all of you, if you can, to oblige me and take your microphone off of mute so that we can give a round of applause to all of our presenters, our moderators, and the planning committee. If you could, please, so they can hear. Thank you so much. Thank you so much. I have been enlightened on so many levels today. If I may be honest, the area of disability as it relates to DEI is an area of need for more learning for me. So I was delighted to find out that this would be the focus of our symposium today. As we think about fostering diverse, equitable, inclusive, safe environments, it is critical for us to consider our employees and learners who have visible and invisible disabilities. It is our mission to ensure all feel welcome, valued, heard, accommodated, but also removing barriers to access to the best of our ability. On behalf of the Diversity, Equity, and Inclusion Cabinet, we value you, we appreciate you, and everything that you bring to KU Medical Center. I would like to take this moment to thank the Symposium Planning Committee led by Kimberly Connolly and Jeff Riddell, and all the amazing presenters. We thank all of you for taking time out to prepare your presentations, but also spending part of your day with us. I also want to thank all the participants. We value your engagement and your contribution to the conversations today. So again, thank you all. This has been an amazing day, and it would not be so without our programming and planning committees. And I again want to thank the leadership of Kim and Jeff for the work that they did, but also our moderators like Ryan, and Alexa and Stacy for their behind the scenes work, because Alexa and Stacy, we cannot do this without you. Now it looks like we need to talk about the assessment. I think the assessment or evaluation will be emailed to you. Please make sure that you complete that. And we also have CE information. And do we need to put that back on the screen for all of our participants, or will we email that information to them as well?
I've put it in the chat many times, but it will also go out by email. So,
okay.
And here it is again.
Okay, well, thank you, Kimberly. Thank you, Jeff. Thank you, everyone. And that's it. I just want to say thank you. And it was a great day. I learned so much. I know I popped in and out several times, but while I was in, I learned a lot of information. So I do want to thank each and every one of you.
Have a great afternoon, everyone. Thanks so much for being together.
Thanks for
joining us. Shout out
to
to Alexa and Stacy again. Good job.